Okay, everybody ready? Want to review this thing? So what the situation is actually is you're working for an endocrinologist, and you're going to see three different patients today: Jorge Alvarez, Janique Johnson, and Mary Smith. So let's start with Jorge, and I'll go ahead and read through some of this. Jorge is a 45-year-old Latino Hispanic male. He works as an accountant and has 3 daughters. He's been a smoker for 20 years. How's his diet? It's about half home-cooked foods and about half fast food items. It's a lot of fast food items. And he usually accompanies that with sweet tea. Has anybody lived in the South? Anybody familiar with sweet tea? Is sweet tea kind of sweet, or is it really sweet? It's really sweet. There's a lot of sugar in sweet tea. Okay. He tries to exercise, but he has a desk job that keeps him pretty stationary. He has been taking walks on the weekends. What about his symptoms? What kind of symptoms is he exhibiting? Tingling in the legs, extremely thirsty, urinating frequently, extremely tired. And he also has, this isn't good, he has a sore on his leg that doesn't seem to be healing. What do we call it when you're extremely thirsty? What's the clinical term for that? Polydipsia. Yep, excessive thirst. And what do we call excessive urination? Polyuria. Okay, question 1, what symptoms is Jorge experiencing? Polydipsia, polyuria, tingling in the legs, tired, sore on his leg that doesn't seem to heal. And so let's look at his chart and see if we can pick anything out. First of all, how's his body mass index? Body mass index is high. He's got a little too much weight for his height. What about triglycerides? Triglycerides are high. Then they did a couple cholesterol tests, HDL and LDL, and his HDLs are a little bit high. But do you know much about cholesterol? There's the good types and the bad types. Is HDL the good or the bad type? It's the good. So that's a little bit high. So we're not too concerned about that. And his LDLs are within normal range, so that's not bad. What about his blood pressure? Blood pressure's high. And let's see, what else? What's another one? What's another big glaring? He's got high glucose. He has hyperglycemia. Extremely high glucose. So we have all these initial values. Is there anything else we want to follow up with on for Jorge? Any questions we want to ask? Sure. Does he have any previous test results for any of this stuff? Yeah, I guess the real thing here is we have hyperglycemia. Okay, and so we want to kind of ask questions that may steer us towards some explanations for the hyperglycemia. And do you have a hunch about what might be causing the hyperglycemia? Diabetes. Yep, potentially type 2 diabetes. And is there a family history component to diabetes? Yes. There is. Okay, so we want to ask about his family history. For type 2 diabetes. Kennedy, did you have something? Yep, family history. There we go. So if we're leaning towards type 2 diabetes, so that's kind of our inclination, what additional tests might we want to run to follow up on this? A C-peptide test, what is that actually measuring? What's that a proxy for? Good. Blood insulin. What else? We want to run a whole host of glucose tests, right? Glucose tolerance test, A1C, fasting glucose, all that type of stuff. Okay, so we got the test results back, and there are a number of test results that are measuring sugar. We have random blood sugar, we have fasting blood sugar, we have a glucose tolerance test, we have hemoglobin A1C, which is a long-term measure of blood glucose. Your blood glucose maybe over the past 3 months. And what are all those values like? All the glucose tests are high. Okay. What else does he have going on? What about his cortisol levels? Cortisol is high. Is cortisol related to high blood sugar? Remember, cortisol is a long-term stress hormone. And what does cortisol do as part of long-term stress? It raises blood sugar. Yep, it raises blood sugar. Exactly. Antibodies against the pancreas. Why are we measuring that? To see if it's an autoimmune disease, if it's potentially type 1 diabetes. Good. I skipped one here. How about the C-peptide? How about his blood insulin levels? They're high. Okay. Urinary glucose. Does he have are you supposed to have sugar in the urine? No. You're not. Does he have sugar in the urine? Yeah. He does. Okay. And what about ketone bodies? Are you supposed to have any ketone bodies in the urine? No. Nope. Does he have ketone bodies in the urine? Okay. And since this is a metabolic thing, we want to measure the thyroid axis, T3 and T4, but those values look within normal limits. Okay. Oh, the T3 is low. Good point. Maybe we can speculate on that. Okay. Let's see. Based on the data, is Jorge producing adequate insulin? No, he has high levels. And that's based on the C-peptide tests. Okay. All of this said and done, can we give a diagnosis for Jorge? Somebody besides David.
Type 2.
Probably type 2 diabetes. Okay. Love the participation, David, but give everybody a chance here. Type 2 diabetes mellitus. And what are some things that are steering us towards that? Hyperglycemia. What else is characteristic of type 2 diabetes that he came in with symptom-wise? Polydipsia, polyuria. He's got that sore that's not healing. So let's say, okay, type 2 diabetes might be a pretty good diagnosis. But let's take it one step further. Do you think he has, based on the data, does he have pre-diabetes or does he have full-on diabetes? Go ahead, Adam. he does have insulin resistance, but what can we, and I'm going to agree with you, yes, he does have pre-diabetes, but what value up here in the chart is really going to steer us toward the pre-diabetes versus the other diabetes? Somebody over on this side of the room. Does this help? Here's a normal, healthy individual. Here's a pre-diabetic, and here's a full diabetic. And the first thing that goes down, you guys know this, from a transition from a healthy individual to a pre-diabetic, what drives that transition? Which one of these variables drives that transition? It's the decrease in insulin sensitivity, right? You have a decrease in insulin sensitivity. And that decrease in insulin sensitivity means that the cells are not responding to insulin, which means they can't take up glucose from the blood. So that's going to cause blood sugar to go up. That's the second thing that happens. So blood sugar starts climbing, which we see for Jorge. And what does the pancreas do in response to this extremely high blood sugar? It releases insulin. It releases high amounts of insulin. And what are Jorge's insulin levels like? Are they high or are they low? They're high. Okay, so that indicates that he's a pre-diabetic. And what causes the transition from a pre-diabetic to a full diabetic? Those beta cells in the pancreas can't keep that up for indefinitely. So the beta cells fail, and then your insulin levels go super low. Okay. So the fact that he has high insulin levels is steering us towards pre-diabetes.
So treatment would be a good diet and exercise plan.
Absolutely. You can reverse that insulin sensitivity. You can do that through diet. Exercise works wonders for reversing that insulin sensitivity, getting it back up high. And is there any maybe medication we want to give him to decrease his blood sugar? What's probably the most common blood sugar lowering medication? Metformin. Good. Now, going back up to the charts, his cortisol levels are high, and cortisol is not, type 2 diabetes and cortisol, I don't think are directly correlated. But if he's stressed, then his cortisol levels are going to be high, and that's going to increase his blood sugar even more. Okay. And what's causing his low T3 levels? That's hard for me to speculate right now. Does anybody have any thoughts on that? Yeah, that's a tough one. That's a tough one. Okay. Do we feel pretty good about Jorge's diagnosis? Good. Next, we're going to move on to Janique Johnson. Janique is a 12-year-old female. She's in 7th grade. She's been on the swim team for the past 4 hours. She's a good student, a happy child, but lately her mother's been worried. Let's see, what kind of things has been going on? She's been irritable the past few months. Mood changes. She's often too tired to attend swimming practice, which is odd because she's a healthy teenager. She's complained of feeling too weak to swim. She's having headaches. And so despite this decreased physical activity, she's been eating almost nonstop. And she's actually lost pounds. She's actually lost pounds despite the fact that she's eating a lot. She's also drinking more than usual, and she's been vomiting frequently. So there's a lot of stuff going on with Janique. She's drinking more than usual. Polydipsia. She's also eating almost nonstop. What poly is that? That's polyphagia. Good. All right, let's check out her chart. How's her body mass index? It's low. Triglycerides are fine. Her HDLs are high, which is not surprising because she exercises a lot. Exercise can increase your HDLs in a good way. What? Say that again?
Her HDLs are supposed to be greater than or equal to 40, so they're not out of range.
Oh, greater or equal then. I see. Yeah. Okay. Good point. Thanks. Let's see. Pulse, hematocrit. What else is out of balance? The glucose. She's hyperglycemic. So she's hyperglycemic. She's exhibiting a couple of the polys. What is this steering us toward? Again, maybe diabetes. And, that can be type 1 or type 2. What additional tests would we want to run to differentiate between type 1 and type 2? We probably want to do all those glucose tests, right? There you go. Antibodies against the pancreas. And then any additional information, type 1 diabetes, autoimmune diseases can be genetic. And so we probably want to know a family history of any autoimmune diseases. All right, what are her blood sugar levels like? They're all high. Her cortisol levels are also high. What about, what about her insulin levels, her C-peptide levels? Those are low. And what about the antibodies against the pancreas? Okay, antibodies against the pancreas are high. Does she have glucose in the urine? She does. Does she have ketone bodies in the urine? Yes, she does. And they also ran some thyroid tests. Why would it be appropriate to run thyroid axis tests? If you had to predict or guess what a potential thyroid disorder that could be causing some of these same symptoms, what would you predict? Hyperthyroidism. Okay. She could be hyperthyroid because her metabolism's up, she's eating, she's losing weight, all that type of stuff. But fortunately, her thyroid levels are within normal range. So what are we going to diagnose Janique with? Type 1 diabetes. And what supports that? Well, she has the polys. She has high blood sugar. And probably most definitively, antibodies against the pancreas. And if she has antibodies against the pancreas, they're attacking those beta cells in the pancreas. What are her insulin levels going to be like? They're going to be low. And in fact, that's what they are. Does it seem uncommon or abnormal that she would be diagnosed with type 1 diabetes as a teenager? Is that something that you're necessarily born with, or can it come on during adolescence? It can come on during adolescence. And so this very well could have just happened to Janique the past few months. What is she going to have to do now as a normal part of her life? She's going to have to monitor blood sugar. And yeah, insulin injections. Okay, do we feel pretty good about the Janique diagnosis? Think so. Good.
I have a question about the how would you explain it? Because since she's a teenager, would you go too into detail, or would you be just like super broad about it so it kind of gets the point across?
Teacher.
Be a teacher, exactly. So, I mean, what ultimately is going on? This is an autoimmune disease, right? And so you'd probably want to explain that this is an autoimmune disease, which means your immune system is attacking the body's own cells. And specifically, they're attacking the cells in the pancreas that produce insulin. And so because of that, her beta cells have been destroyed, and so she can no longer produce insulin. And so she's going to have to administer that insulin herself for the rest of her life. There is stem cell therapy where they're trying to replace those beta cells, but I don't know if that's quite there yet. Okay, then part 3, we have Mary Smith. Mary's a 40-year-old female. She sits behind a desk for the majority of the day. She hasn't been feeling like herself lately. She has a handful of symptoms. She's been tired, a little depressed. She's gained weight, especially around her belly, and also her face feels fuller than normal. So she's feeling some weight gain in some particular areas in the belly and in the face. Her menstrual cycles have become irregular. And she also has some facial hair growth as well. Let's look at her chart. What about her body mass index? Body mass index is high. Triglycerides, high. Cholesterol looks within normal range. Glucose levels are high. Did I miss anything? Sodium is slightly high, and blood pressure is slightly high as well. So in this instance here, she does have hyperglycemia, so we probably want to do all the glucose tests and do all that type of stuff. But what's really irregular is that she's gaining weight around her belly and in her face. And if you're around endocrinology a lot and some endocrinology disorders, this kind of points towards a certain endocrine disorder. Okay. Let's see. So she does all of the blood sugar tests, and all these blood sugar tests are high. She also has elevated cortisol. They also did something called a DEX challenge. And you can go to the last page and it'll tell you what a DEX challenge is. Dexamethasone is a synthetic glucocorticoid. And so they're going to give her exogenous cortisol, basically. And they're testing whether or not that cortisol is going to inhibit the release of ACTH from the anterior pituitary. So this would be a good time to maybe draw out the endocrine axis for the adrenal gland. Okay, that's oops. That starts up in the hypothalamus. And what is the hypothalamus release to start the adrenal axis? CRH. And that is going to act, where's that CRH going to act on? The anterior pituitary. And what's the anterior pituitary going to release in response? ACTH. ACTH goes into the blood. And where's ACTH going to act? It's going to act on the adrenal gland, specifically on the adrenal cortex. And what's the adrenal cortex going to release in response? Cortisol and aldosterone. Okay, we'll stick with cortisol for now. And so what they're doing with this DEX test is they're basically increasing the amount of cortisol in the body. And they want to determine whether or not that has an effect on ACTH levels. What should high levels of cortisol do to ACTH? They should lower it based on negative feedback. So when cortisol levels get high, that acts back on the hypothalamus and on the anterior pituitary, and it decreases the amount of both of those hormones. So with the DEX challenge, we should have low levels. We should have low levels of ACTH. Okay. And in fact, when they did the DEX challenge, what are her ACTH levels like? Super high. So something's going on. What does that tell you? Tells you that maybe ACTH is coming from some other area of the body besides the anterior pituitary, because that cortisol should be down regulating the levels of ACTH. Or what else could it tell you about the anterior pituitary? There could be a tumor on the anterior pituitary. It could be a hormone producing tumor where she's producing all of these high levels of ACTH. Okay. But that's really the thing that's going on, is she has high levels of ACTH. And she also has high levels of cortisol. Anything else abnormal? Oh, there we go. Look, high levels of testosterone. So she has a couple things going on. She has high levels of cortisol, and she has high levels of ACTH, and also high levels of testosterone. Can anybody think of a correlation or a reason why high ACTH levels may result in high levels of testosterone? Remember, the adrenal cortex also produces androgens. Okay, so it is possible that these high levels of ACTH are stimulating the adrenal cortex and resulting in high levels of testosterone as well. And would high levels of testosterone explain any other symptoms? That facial hair, exactly. Okay, what would you expect DX to do to Mary's ACTH levels? We expect those to decrease the ACTH levels and also decrease the cortisol levels as well. Because if ACTH goes down, cortisol should go down with it. Let's see. They also did an MRI. And what might they be looking for in the brain? Yeah, a tumor, and maybe a tumor on that anterior pituitary. That would explain the increase in ACTH, right? But that's not the case. It was clear. But was there anything suspicious going on? The peritoneal cavity, the abdominal cavity, she has lumps in the peritoneal cavity. I'm trying to think. I haven't thought about this question here, so I was just going to ignore it. What diagnosis do the baseline and post-dex results suggest? Let's see. The fasting morning, her cortisol levels were high. 9 hours post-dex, they were again high. Her ACTH levels are high. Well, to me, that indicates that there's something going on outside of this axis that are causing ACTH levels to be high, basically. And again, if you're an endocrinologist, you might know this, but high levels of cortisol, chronically high levels of cortisol can result in an increase of fat deposition in the abdomen and in the face. And what that is called is Cushing syndrome, high levels of cortisol. And if you look up some of the features of Cushing syndrome, they should really think of some better names for this, but you do have a fullness in the face. They call that a moon face appearance. That's not very compassionate, is it? It also results, it can result in fat deposition in the upper part of the back, so that you can get a hump of fat in the back as well, and it can result in increased abdominal fat. And I was doing some research on Cushing syndrome and what can cause it, and there are a few things that can cause it. One, like we mentioned, you can have a tumor on the anterior pituitary. So one thing that could be happening is she could have an anterior pituitary tumor that's resulting in high ACTH levels. Okay. But do we think that's the case? No, because her brain MRI was clear. Another thing that can be happening is that she could have a tumor on the adrenal gland itself. And that would result in high levels of cortisol. But if that were the case, if she had a tumor on the adrenal gland that was resulting in high levels of cortisol, what should that do to ACTH levels? She should have low ACTH. And is that the case? It's not. And then the third way that this can happen, and they call this ectopic Cushing's syndrome or Cushing's disease, is when you have a tumor, you have an ACTH producing tumor that's located somewhere else in the body besides the anterior pituitary. And based on her MRI, where she has these lumps in the abdominal cavity, it's likely that she has a tumor in the abdominal cavity that's resulting in elevated levels of ACTH. And if you have elevated levels of ACTH, what's going to happen to your cortisol levels? You're going to have high cortisol levels. And then what did they try to do? Well, they were like, okay, well, let's give a Dex injection, which is basically elevated cortisol. And, that should act back and decrease the levels of ACTH. And maybe it did decrease the levels of ACTH coming from the anterior pituitary, but you have this tumor in there that's producing it on its own. Okay, so that last one was kind of difficult, but one of the reasons I like this case study is because we have hyperglycemia in 3 cases, and really we have 3 different causes of the hyperglycemia. Yeah. Yeah, I guess that's the next question. What treatment would you recommend for this patient? Let's get in there and remove the tumor. And hopefully that'll solve the problem.